Hello everyone. This is the Q&A follow-up from the Vasopressor webinar that we did on the 15th. Sorry I got to it late, but I think I tried to write down everything with Dr. Shu. It's about, 25 questions or so. So let's get through them. The first one is, I'll try to answer the questions that are not specifically answered in the webinar itself, because I think we shared the YouTube video. Regardless, I'll still answer the questions if they're kind of brief to an extent. So the first question is how to titrate vasopressors and inotropic drug dosage in critically ill children. And so there is no universal or protocolized or right way of titrating it, but it really depends on how you're starting it. So if you started norepinephrine, let's say, for an septic shock kid with no myocardial suppression and norepi at 0.02 mics per kg per minute, you can continue to titrate up by 0.01 or 0.02 every 5 to 15 minutes. So you can give it time to have all of its effect as long as the hemodynamics are improving or see a change in the hemodynamics. And once you reach 0.08 to 0.1, that's when you start considering the second line agent, where you would say, I'm going to use epinephrine, and you would start that at 0.02 as well, on titrate up by 0.01 mics per kg per minute every 5 to 15 minutes. I think once you reach 0.15 of each or 0.2 of each, it goes from there as a risk versus benefit and how much you'll actually get benefit from these pressors. And at the stage where you're sitting between 0.15, I would believe, on both, or by the time you're starting a second pressor and escalating on it, I would start thinking of stress dose hydrocortisone, and you start it by 100 milligrams per meter square as a bolus dose, knowing that it has more of a delayed effect rather than immediate effect like the pressors. And then we'd follow that usually with a 25 mg per kg, 25 mg per meter square, Q6 hours of hydrocortisone for maintenance doses. And if these pressors are not working, you usually start jumping for your third line, which is vasopressin. And you start it at like 0.1 or 0.2, and you titrate up to like 0.6 and units per kg per minute. And I don't see us usually go above 0.6 as much, because you have to negate the effects of vasopressin as a vasopressor and vasopressin as a DI medication as well. Second question is, what are the long-term risk factors or risks of vasopressin inotropes using in children from an anesthetic and critical care perspective, and how can they be mitigated? So I think it's hard to define long-term. By long-term, do we mean that these patients are on dual pressors of 0.2 of epinephrine and norepinephrine for about 24 hours? Or are we implying that it's been several days on such support? Or are we saying that, for me at least, for a long time, I would negate it as a patient who's on pressors that you're escalating and you're not seeing improvement within 2 to 3 hours or within the 6 hours that you're monitoring the patient over, that you should start thinking of, is this patient stuck on high dose vasopressors without any meaningful improvement in these patients? What should I use as adjuvant therapies? What I should use as my third line? Should I start considering ECMO early? Is this patient even ECMO candidate for VV or VA? Most probably VA. And it's not an escape strategy, it's a backup strategy that you're thinking ahead with the end in mind. And the major risk factors that we usually see is limb ischemia. We also see reduced renal perfusion function, and we see compromised gut perfusion. These are the three things that we usually look for when you're on pressors. The third question goes to refractory septic shock with multi-organ dysfunction. How would you minimize the risks of tachyarrhythmia and end-organ hypoperfusion? So this is a difficult balance to strike overall, because we know at specific stages, all of this is driven by largely weighing your benefits versus your risks on these patients. And we know that epinephrine is more likely than norepinephrine to cause tachycardia, But we know also that if you're looking at the patients and their degree of heart rate is not much corresponding to their degree of shock, you should be concerned about myocardial affection, right? You don't want a patient to be bradycardic or bradycardic or having a normal heart rate when they're in shock state, because you anticipate their cardiac output to be increased by going higher on their heart rate. Unless you're doing an amazing job resuscitating them and their hemodynamics are becoming more stable and their heart rate is starting to normalize as their blood pressure is starting to normalize as well. So epinephrine will cause tachycardia, norepinephrine less likely, and you start thinking of dopamine. Dopamine is, on the other hand, is more or less a pro-arrhythmogenic drug, more in adults than pediatrics, but also pediatrics, and you're thinking more of atrial arrhythmias that occur with dopamine. And it's also been compared to have a higher mortalities when compared to dopamine and epinephrine, or dopamine with norepinephrine. It seems like there's higher mortality, and we'll talk more about dopamine, but dopamine itself is known for having a higher risk of arrhythmias than epinephrine or norepinephrine. Common adverse effects that we see with norepinephrine in critically ill children, and how evidence-based approach are available to address them. So we mentioned limb ischemia as one of the common ones, and gut ischemia, renal perfusion. And I think for gut ischemia and renal perfusion, you're really, again, thinking of saving the vital organs and thinking how you can get renal perfusion with reaching more euvolemic state, glycemia resuscitation phase, and then you try to deresuscitate the patient and see where your renal perfusion will sit. But let's focus on the limb ischemia. So in literature, they're usually predominantly seen it in adults, where they categorize limb ischemia secondary to pressor uses in 4 phases, 1, 2, 3, and 4. And phase 1 is basically, the treatment for it is what we usually do is like using bear huggers, putting cream like nitroglycerin, which helps vasodilate the extremities. And of course, starting phase 2 and above, this is more invasive, where you do fasciotomies up to ranges to amputations. But things to negate it is usually, at times you give Botox, at times you do phentolamine, at times you do bear huggers, and I will try to add this in the document that we'll attach. Now, when it comes to what should I do in a vasopressor shock that does not respond to high dose pressors. So by this stage, we're usually already gave the stress dose hydrocortisone. We already aided vasopressin as our third line. And as emphasized in the lecture that we gave, start with the end in mind, right? You want to see, will this patient get liberated from the pressors or the shock state? This patient trajectory is what I anticipate it to be, and how can I anticipate the trajectory knowing the resources I have and the accumulated experience that I've seen other patients with septic shock from before. And at this point, you're starting to think, if this kid is vasoplegic shock, not responding to pressors, should I start thinking of VA ECMO for these patients? Should I start using adjuvant therapies as a bridge to VA ECMO, knowing that the literature does not support as much outcomes from these medications, but we still use them? For example, methylene blue and angiotensin 2, and their dose is like 20 mics per kg per minute. That we run it, we usually give a bolus dose in the methylene blue over 20 minutes, and then we run it to see effect. But we have to understand that these are like temporizing adjuvant therapies until we bridge this patient to a more definitive support, until this SIRS reaction or septic shock can able to be subside, and that's where kind of VA ECMO comes. But we also know kind of outcomes of septic shock patients on VA ECMO is a different story that we can discuss in a different day. So another one is asking, as a clinical dietitian, we use VDE score for high vasopressors in adults, and we provide trophic enteral feeds depending on it. Is it the same in pediatrics? Does the vasopressors are considered, what dose of vasopressors are considered to be high? is it 0.15 or more. So in adult versus pediatrics is different. Adult, we have higher tolerance of pressors than in pediatric patients. At least in my institution, what we usually use is pediatric vasoactive inotropic scoring, and it's a tool to quantify the degree of pressor needs, whether it's dopamine, epinephrine, norepinephrine, vasopressin, milrinone, and quantify it in a score that help guide you of the pressure burden that the patient is on, and it's mainly used for research purposes. Now, when it comes to enteral feeds, we don't guide it by the score itself. We usually guide it by the clinical of the patient. Per Aspen and Surviving Sepsis campaign, usually you're trying to avoid to use TPN, total parenteral nutrition, or early parenteral nutrition, up to 7 days. So after 7 days, you want to give them this because there's a higher risk of mortalities, higher risks of bacteremia and sepsis, and prolonged hospitalization. So when we come to enteric feeds, we said there's a risk of gut perfusion, especially with norepinephrine, but also happens with epinephrine. Or overall, there's gut shunting when there's a shock state to the vital organs. There is no clear-cut cutoff point on dosage and when to stop feeds or when to start feeds in pediatric patients. So it varies on individuals, and what we've pretty seen is if the patient's trajectory after 48 hours is improving, we're weaning down our pressors, and let's say we're in a monotherapy of pressors at less than 0.1, we can usually start feeds. But if it's higher than that, that's a different story, and it can go based on your preference as an individual and your clinical sense whether you want to feed the patient or more. I usually only see us feed at less than 0.1 mics per kg per minute of a specific of a monotherapy. Other than that, it's really guided by the patient clinical diagnosis, as we mentioned before. How does norepinephrine mechanism of action differ than dopamine, and why would choose one versus the other? And I think we answered that in the lecture, but what I would just highlight is think of dopamine as it's labeled as like dirty dopa, and because it comes with such different side effects and such different effects that are not as specific as when you use only epinephrine or norepinephrine. We know it comes in different doses, so less than 5 mics per kg per minute it predominantly acts on dopaminergic. From 5 to 10 it acts on the beta, and more than 10 it acts on the alpha. But we know, again, as I mentioned earlier, when compared, it has a higher mortality risk, it's more pro-arthrogenic, and think of it as a precursor drug to norepinephrine and epinephrine. So wouldn't it be easy, even though the dopamine increases renal perfusion pressure and used more in NICU population, wouldn't it be better for you to use solely norepinephrine versus epinephrine? And to use it is honestly based on your resources. Surviving Sepsis campaign did not say norepinephrine versus epinephrine as a first line. They said you can use it based on what you think you should use, and it comes in, is it, for example, a shock without myocardial suppression and you only need a peripheral increase of SVR, so you would use norepinephrine, or there's an element of myocardial suppression stun that you use epinephrine to help with your squeeze itself. And I looked at the cost in the US versus outside of the US in dollars about the epinephrine, norepinephrine, and dopamine, and it seems like epinephrine is the cheapest of the three and the more available overall for you. What is the recommended for first-line vasopressors and fluid refractory shock, which I think I mentioned in the previous question that Surviving Sepsis campaign did not specifically recommend one versus the other. I think they said just put in context which one do you need. Do you need a higher SVR at this moment, or do you need more support of the heart when you're starting these patients? And they just avoided using vasopressin or dopamine as your first line. What is the highest dose of epi or norepi? In theory, there is no max dose, and there's a saying like until the limbs fall off, like as high as you can negate without side effects. And I think once you are at 0.15 mics per kg per minute of both of them as dual therapy or 0.2, from my mentor's experience, from my experience, from the literature, I don't see more benefit from being above 0.2 when you're having a higher risk profile than your benefits. So at that time, maybe you should be already started to think of adjuvant therapies that you could use. Now, I've seen the highest I've seen, I think, is 0.5 and 0.5, but then to what end is the question that you should always have in mind. But again, technically, there's no max dose on pressors. What is the difference between vasopressors and inotropes in terms of mechanism of action? So I think, let's clarify a few terms. There's vasoactives, and vasoactives are whether you increase your SVR or decrease your SVR. So vasoactives are, like, for example, nicardipine and nitroprusside for hypertension. So you start those trips to decrease the as an antihypertensive medication. But you also have on the other side vasopressors, which are epinephrine, which one's on vasopressin, which causes vasoconstriction. So these are the vasoactives, and vasopressors are part of that. So when it comes to inotropes, there's inotropy, there's chronotropy, and there's leucinotropy. And you have to understand, inotropy is drugs that help the heart contract. Chronotropy is those that help affect the heart rate itself. So we know that the cardiac output is basically heart rate and stroke volume. So think of inotropes as those to help you contract, and think of chronotropic drugs, that ones that help you contract faster. So affects your heart rate. And then leucinotropy, like milrinone, help the heart relax in diastole more, which allows more coronary perfusion pressure, and hence the benefits of milrinone overall. Should we take a cortisol sample prior to giving steroids? If the time permits, get a cortisol sample, send it, or add it onto your labs, and then give you just the steroids. It might help you to understand whether their steroids was low before or not, random steroids was random total cortisol, was it normal or not? But the question is, will it stop you from giving the steroids? I haven't seen it stopping us, and I haven't seen an indication that you only give it if your cortisol is low. But we usually draw a level of steroids ahead of time, and then we still give at least the loading dose, and then you'd see where they sit, and maybe you can determine based on your serum total random cortisol whether you want to add maintenance to that or not afterwards. What algorithms that we use if we need to use vasopressors in children? There's so many algorithms that are open source. I think there are some from SHOP, there's some from Seattle, there is TCH. And again, it's really always based on institutional guidelines as well. What is if the patient is still hypotensive after titrating their epi and epi to 0.2 and adding vasopressin and adding corticosteroids? Do we increase the dose more? And I think we answered that by saying risk versus benefit. Again, I've seen as high as 0.5. And is it a wait and see game right now? Are you having availability to have ECMO already on board, and would you start ECMO earlier than that so you basically avoid all of this vasoconstriction? It's a hard question that is answered by how much resources you have and how the clinical patient is. Are you maxed in this and you are supporting them completely, and you don't have ECMO, it might be a waiting game at that point. You can still again use methylene blue, you can use angiotensin, you can look for the causes that you might be missing. So is this a cardiogenic shock that is hidden? Will this patient benefit from milrinone if we add it onto it? Well, there are other markers of shock. Is this a patient that is in obstructive shock? So you start looking for tension pneumothorax, which I'm sure you've already been troubleshooting that. Pericardial effusion causing pericardial tamponade, other causes that you can go for. But if you're hitting vasoplesic shock, it might be at times hard to recover from it, and you start to thinking again for like ECMO patients and cannulation candidacy. Indications of methylene blue is the same question as before that we mentioned if you have a vasoplesic shock. Especially the main literature comes from coronary pulmonary bypass in these patients. Can we start norepinephrine peripherally? Yes, you can, until you have central. There are a lot of patients that they clinically looks well, but they're hypotensive and we know they're in shock, but their mentation is well, and you're hesitant about intubating them and putting a central line, because you'll probably put a central line after you do sedations and intubate the patient and do central line, and you're not, and their mental exam is really good that you don't want to intubate and sedate these patients. You can run it through a large bore PIV if you can, and you'd prefer to avoid like 24. You want to do at least at 20. We've seen us run at 22, but you want something that would survive, and then you have to do limb check if you're running pressors almost every hour, at times even more. And we usually keep the dose below 0.1. And once you think you're rising by 0.1, or you need another pressors, then you start thinking of, you know what, maybe I just need to intubate, sedate this patient, take away their metabolic demands, or decrease their metabolic demands and put in a central line. What if we have myocarditis and still we have hypotension, although maximal intraocular support? Can we use Miller-None? You can still use Miller-None if you feel there's diastolic heart failure, recognizing that Miller-None you can start at 0.2 mics per kg, 0.25 mics per kg per minute, 8.5, you can escalate to 0.5, and you would know that there's usually a delayed effect of Miller-None for decreased renal perfusion and decreasing your SVR later on as well, and that usually happens 6 to 12 hours after initiation of Miller-None. But the question here in these patients with myocarditis, what's their ejection fraction, and is it bad enough that you just need to do VA ECMO to support the patient's hemodynamics until the myocardial supportive treatments is done? And this is important for you to know. At what dose you consider VA ECMO, and I always think of ECMO candidacy when you have a patient in septic shock. Do not wait until you're stuck at 0.2 and 0.2 and you don't know where to go. In the settings where you cannot get a central line, for how long can we give vasoactive peripherally? Honestly, it depends on the run, but I've seen us give 4 to 6 hours, maybe 12 hours on a peripheral vasopressor, and see if there is a improved trajectory of this patient clinical outcomes. Then we usually leave it peripherally, and if we started to see that no, this is getting more towards worsening hemodynamics and worsening outcomes, then no. Then at that time, what we would do is we'd start the patient on central vasoactives. I hope that helps.